Welcome to our webinar to the endoscopic spine surgery in pandemic crisis. It's a great honor to meet us in our passion, the minimal invasive techniques in the spine.
My name is Dr. Fernando Torres. I'm spine surgeon, the president of the Colombian Society of Spine Surgery in Colombia, which is part of the Colombian Society of Orthopedic Surgery. Our discussion will be endoscopic spine surgery. Endoscopy has developed because optics have developed microscopes, viewing fiber optics seen on 4K, full HD monitors. And we are going to be talking about robotic surgery, endoscopic surgery that we are performing nowadays with great help from navigation in the spine. It's an important advancement, and it is really a source of pride for us here, specifically also smart operating rooms. In the background, you can see the facilities of CLEMI, just like in Spain, you have the Jesus Uson Institute. We have CLEMI, where we have simulated our work in cadavers, and we have developed our uniportal and interforaminal approaches. We have conducted several courses in Latin America, and we are following the same school of the Jesus Uson Institute in Spain. And we have at CLEMI optics, C-arms, and all the instruments available for the uniportal and biportal technique. As I was saying, we have worked on cadavers, and we created a document. It is not translated, but we are in the midst of this pandemic that has killed many people. And that is the reason why we have developed this talk. We cannot do surgeries that will end with the patient in the ICU because the patient will have some form of contagion or contingency. So only the emergencies will be dealt with. Any emergency secondary to tumors or compression or fractures. We have looked into guidelines of different parts of the world where unstable fractures are operated, epidural hematomas, surgical site infections, CSF leaks, which we consider emergencies, and urgencies are procedures that can be managed orthopedically, or we can manage through medical management. For example, spondylodiscitis, deformities with neurological deficits, which are urgencies, but which can be delayed, and stable fractures, types A3, A4, or unstable pathological fractures with non-neurological deficits, which can be delayed. And during the pandemics, definitely we cannot perform elective surgeries, those situations or conditions, for example, spinal deformities with no neurological deficit. We don't take these patients to surgery in pandemics, but we do have endoscopic spine surgery, which has allowed us to continue to operate, to continue to treat our patients. And we have very important experience in the country. We have used the biportal, the BESS, and we have had very gratifying experiences because we can treat all those urgencies and emergencies in an effective way. avoiding contagion in our hospitals for our patients. But we have managed all of our patients as if they were all infected with the COVID-19 virus. And the indications that we have used in the pandemic are progressive neurological deficit. It's in accordance with our document that I showed you previously. Deformities, scoliosis, and kyphosis, untreatable pain syndrome, post-cystectomy syndrome, exacerbated chronic pain. These entities are amenable to operation with BES, with endoscopic spine surgery. Indications for interlaminar BES, for example, because it can also be done transforaminal in the interlaminar. These are the indications. This disease, stenotic spine spondylolisthesis grade 1. We don't need to do fixation in lumbar stenosis. It is also very important that we can decompress using BES, grade 1 spondylolysis and degenerative scoliosis, because the most important symptoms are due to root compression. And we can see that at the level of L4 or A5, the compression is of excellent quality. There is also the Foraminal Approach. We can act on it. Here we're seeing L5S1 without the need to use extreme positions. So with the 4 mm lens, we gain access and we can treat foraminal stenosis, we can treat foraminal disc, herniations, post-cystectomy syndrome, far lateral syndrome, and even when there are broad laminectomies, we can play cages as well. And these are the contraindications, of course, tumors, fractures, and spinal instability. The technique that we use is biportal technique. We use a conventional endoscope with a 0-30-degree lens, and patients, we are protected with, we use double masks, face masks, all the PPE in the epidemic, and we have been able to work effectively with our patients. We do not only perform discectomies, we can visualize very well. The lateral processes can be visualized very well, very accurately, and it is very easy to maneuver. It's an easy technique. We can, of course, work on training in cadavers, and once we learn it, it fulfills the criteria of optimum surgery. This is the before and after for the treatment of lumbar stenosis. As you can see, it is not only the disc, but we can adequately decompress the canal. And the MRI immediately after surgery shows the significant decompression of the foramina as well as of the central portion, those pathologies that we are understanding much, much better through these types of interventions. Disc disease, comorbidities, so we can operate obese, older patients with diabetes and hypertension, and we can actually broaden our surgical possibilities. Patients with Parkinson's disease, we went in and we could see the pedicles, the roots, and we can perform foraminoplasties in a very accurate way. And this transforaminal technique for L5S1 is very easy to perform. And we now have the possibility of treating disease conditions which we didn't even know previously. Lateral recesses, different multi-levels in patients who have been operated previously. In the elderly, the transforaminal approach allows you to have a very accurate approach. You can see the foramen, how you can see it very clearly. You can even see the anatomy of the root and the foramen. And for scoliosis, treatments in levels of scoliosis, we don't treat the deformity, but we can treat pain. Take-home messages in the pandemic is that the patient should not be taken to the ICU. There is less bleeding, low analgesic doses. The patient, according to the indications, can be discharged before 24 hours to avoid any complication of colonization due to coronavirus, and the patient recovers. So lenses, arthroscopic devices are available in all hospitals. We can operate in all age ranges. The C-arm can be used in multiple operating rooms. They are needed for other specialties, so we can just take 1 or 2 images and there is a very low dose of irradiation. During the pandemic, we avoid propagation of aerosols. Intraoperative time is short, no blood transfusions. We can do it even with an epidural catheter, and we can work in patients with comorbidities like obesity, hypertension, diabetes, heart disease, and with navigation, we can make just 1 film, and we achieve great accuracy. Thank you very much for your attention, and let us not forget our sponsor, C&S Medical. And now we will continue with Dr. Day, who will be talking about his own experience. Thank you.
Please continue, Dr. I'm welcome, Dr. Kuopin. It's a pleasure to be with you this night. Please, Dr. Daeju, please continue your task.
Thank you. Good afternoon. Hi, everybody. I'm very happy, and I'm it's my very big honor to me. And congratulations of big endoscopic webinar symposium. I will share my screen first. Okay. Okay. Can you see me? Okay, I will start. Today's my presentation topic is the basic technique. Today's my topic is biportal endoscopic spine surgery, and especially basic concept and basic technique. What is the difference of biportal surgery from endoscopic uniportal endoscopic surgery or open surgery? This is a biportal surgery. We use the screen and the arthroscope and every other instruments, general instruments, which are used in open surgery. I think somebody asked me what's the difference from the uniportal surgery, biportal surgery, or the microscopic surgery. But in these days, I think the unique different concept is floating technique or docking technique. The portal number is not important. Sometimes I use 3 portals or 4 portals. But the difference is the docking to the Kambin's triangle. It is generally for the uniportal surgery, and we use the floating technique in biportal surgery. In these days, uniportal surgeons use the floating technique for foraminal decompression. Then it is the same technique for uniportal and biportal is the same technique. So the unique difference is the floating technique or docking technique to the canvas triangle. When we put the scope floating it needs some distance from the target, 1 or 2 centimeter, maybe about 1 centimeter. We can move the scope so we can see the structures wider, and we are moving freely. And through between the gap, we insert every instruments which are generally used in open surgery. But the weak point is from the space, every small bleed comes to my eyes, so the surgical field can easily blur. So it is difficult. So the main technique of this biportal surgery is how to make water output fluently. And the second, we should know where the bleeding comes out. When we overcome 2 things, every surgery is just the same as a microscopic open surgery. So I will show you my technique, how to make the water output fluent. When we inside the skin, after skin incision, we have to cut the fascia, subcutaneous fascia. But just only transverse 1 incision, we cannot make a way for fluent output water. So I added cross cut to the midline, and the fascia can be opened wider when we put the scope and pull down. The fascia will open wider, so the water comes out more frontally. And I use a muscle dilator, 1 centimeter diameter, and I make a tunnel through the 2 bottles at the same place, mostly at the interlaminar space. And then the final trick is, everybody thinks that water is trapped in the muscle. No way. The water is not trapped in the motor. The water is stopped just under the subcutaneous fat. So after incise the fascia wider and put the scope and infuse the water, when the water does not come out fluently, then just try to remove the subcutaneous fat. It's a plug just under the skin. Then you can get the water fluently. So on the video clip, I make a way at the same point at the interlaminar space, and put the scope, infuse the water, and I will show another trick. Just to shake it to and fro, it is very helpful trick. The shaking can evacuate the hematoma underside, and we can get the clear view inside. And the water is not fluent, which I just remove the subcutaneous fat 2 or 3 times. Then water comes out fluently. And the next trick is, we have to know where the bleeding comes out. It is very heavy bleeding. So if you do not control this big bleeding, you will be a big trouble. So in the extraforaminal side, there are main 3 bleedings. Every bleeding starts from the segmental artery. The first bleeding comes out from the left side at 9 o'clock. When you put the scope, if there is a heavy bleeding, please coagulate left side 9 o'clock direction. It is the inferior articulatory from the upper level. After coagulation dead, we move to the scope to find the supraarticular process tip, just a facet joint. At that time, under the muscle at the 12 o'clock direction, there is a heavy bleeding like a rain. So coagulate under the muscle at 12 o'clock direction. Then we can get the clear view. After that, we do capsulotomy. But just under the capsule, there is the interarticular artery, just proximal to the supraarticular process. So we should be prepared for coagulation for this bleeding, big bleeding from the interarticular artery. So after coagulation, 3 arteries, control of 3 big arteries, we can get a clear view during the surgery. Now I move to the posterior side. Posterior side also have 3 bleeding focus. The position is 12 o'clock, 9 o'clock left, 7 o'clock below, and the right side, 5 o'clock direction, just below the facet end. So on the video clip, I coagulate the 7 o'clock direction, and I try to go into the laminar space, and at the end of the facet, there is another big bleeding. That way. So we should prepare for coagulation when we're passing at that point. So after coagulation, 3 big bleeding, always we can get a clear view. Now we move to the approaches and corridor. Approach is the posterior approach when you stand on the left for the left side lesion. Contralateral approach means you intentionally stand on the opposite side, on the left, for the right side foraminal lesion. And the bilateral approach means the extraforaminal lesion. Corridor is the concept of how can we access, how can we reach the target point. In front of the lesion, there are bony structures hiding them. So we have to move, we have to resect, we have to escape that mountain and river and access safely that lesion. So we have to have a concept of corridor. I will show you my corridor. In severe stenosis, the disc height is collapsed already, so the working place, interlaminar space, is very narrow. So sometimes interlaminar space is only 5 millimeters. But the scope wearing sheath is 8 millimeters, and the instrument is about 3 to 5 millimeters. So we need at least 13 to 15 working place when you try to put 2 instruments in the same place. So we should make at least 15. Then we should resect the spinal process space first, proximally and distally. I generally use a chisel. Using a chisel, just a 2 or 3 millimeter resecting of the proximal spinal process space first. Like that. Sometimes it is very hard, but sometimes it's very easy in osteoporotic patient. And using a Carrison punch, I can remove them. Then we can get some more space. And then I move to the distally and I try to remove the distal spinal process space. Sometimes it is very hard, so it is difficult. But when you're using a burr, wow, we cannot reach that area. Burring is not effective to eliminate distal spinal process. So using a chisel, 3 or 4 millimeter resection of this area can give you enough working space. Then we can see its lateral and the contralateral side fully. So when using a chisel, just try to break near cortex first, and then strong one more punch can break it far cortex. And after resecting proximal spinous process base and distal spinous process base, I do the medial side laminectomy. Generally, I perform the spinous process base resection and the medial side laminectomy simultaneously. So at the high reach, just break it, the medial surface of the lamina. We don't need too much resection of the lamina. Just resect the medial surface. Very little piece of resection is enough. And cancellous bone bleeding can be controlled by bone loss. Yeah, like that. Then the working space, we can get the working space well. Well, for the contralateral approach, we can see the contralateral side. But don't try to do much resection of the contralateral side of lamina. Only 2 millimeter resection from the ventral margin is enough to see the supraarticular process, the lower lamina. So only 2 millimeter resection is enough. After breaking it, the lower margin of the ventral part of the contralateral side of lamina, and I try to remove the piece, the broken piece, and then I remove. After removing the piece, I remove the ligament flavum a little bit more. Then I can see the lower lamina. That's enough. That's enough. So we can see the supraarticular process tip of the contralateral side of lower lamina. When sometimes the foraminal contralateral side of foraminal lesion or a migration disc on the contralateral side, we need to see the exiting root on the contralateral side. So after 2 millimeter resection, if you want to see the contralateral side exited lamina, 2 millimeter, once more, 2 millimeter resection is enough. Then we can see the foramen on the contralateral side. That's enough. Yeah. After supraarticular process resection on the contralateral side, we can see the disc and we can see the root. How can we access the contralateral side? I will check the CM. So the instrument and scope is located just under the foramen. So we can access there. That is the corridor concept. Exact amount of resection of bone, after that, we can access the target definitely. So I will show you the video clips. After resection of the supraarticular process of the lower lamina on the contralateral side, and using a curette, we remove the fragment and the foraminal ligament flavum, and then we can see the exiting root. That is the contralateral approach. Now we move to the extraforaminal approaches, shortly bilateral approach. When you put the scope at first the trial on the bilateral approach, it's natural. We cannot see anything. We just see only red screen. Every whole area is blood and the fat and the muscles. We cannot see the bony structures. When you get the orientation in the foraminal approach, we should see the bony structure first. Then we can get the exact right orientation. So the portal is started 2 centimeters apart from the lateral margin of the pedicle and landing down on the transverse process bony surface first. So exposing the dorsal surface of the transverse process is the first trick. Don't touch the left 9 o'clock direction. There is a bleeding area. Only distal half dissection exposure is enough. After that, we move to the foramen. How can we move? How can you find the foramen without C-arm? Without C-arm, we are going to the foramen exactly. So from the, we have knowledge, we have understanding of the structure, and we have knowledge of the reference anatomy. The reference anatomy on the bilateral approach is a musculotendinous bundle attaching the accessor process on the distal tip of the transverse process. So touch down the TP when you find the muscle bundle at the accessor process, and look up the sky on the screen at 12 o'clock direction and move to 2 o'clock direction. Then we can find the supraarticular process tip. So there's a magic spell. Touch down the TP and look up the sky at 12 o'clock direction on the screen and move 2 o'clock direction. That there is always a supraarticular process. So after resecting that, remove the foraminal ligament flavum, we can find the excipient root. When you lose your orientation, you are going to deeper and deeper and deeper ventrally. Then you can infuse the water in the abdomen and you can make a hydroperitoneum. Or infuse more and more and more, you can make a hydrothorax. So you should be careful at first 1 or 2 trial. And remember, touch down the TP and look up the sky. That is a magic spell. So please remember this picture, Kung Fu Fist. You know, you already see many Chinese action movie, Kung Fu Fist, the Hai Shibu. So it is a extraforaminal approach anatomy. The wrist is the TP, the CMC joint at thumb is the accessor process, and the thumb is the empty fiber. Supraarticular process is located always over the musculotendinous fibers. Remember this picture. Then you can get the orientation at every cases. On the right side is more easy. The touchdown TP follow the facet wall, bony wall, and goes up, and you can easily find the tip of the supraarticular process. Right side is easy. Then just break it, the tip of the SAP with chisel, and we can see the foramen inside. So in this time, everybody asks how to escape the dura tear. In the interlaminar space, in the midline, there are 3 layers of the structures: ligament flavum, epidural fat, and dura. So there are 2 spaces. One space is between ligament flavum and epidural fat, and the other space is the epidural fat and dura. Don't go below the epidural fat. There is a big lion waiting to swallow you. Don't go under the epidural fat bush. There is a lion. The safe way is the ligament flavum and epidural fat space. So when you access, when you cross the midline, don't touch under the fat layer. We should go over the fat layer. Always there's a big lion under the fat bush. So don't put any instrument under the fat epidural fat bush. So, okay, there is a dura folding. Cell line compress the dura, so the midline of the dura is collapsed. So under the fat layer, there is a folding of the dura. So when you insert any instrument under the fat layer, you can directly injure the dura and you can make a dura tear. So if you do not want to make a dura tear, always always try to go over the fat. Yeah, it is a dura folding, but it's very thin. So sometimes we misunderstood is just a fibrous tissue. No, at the midline, there's always the dura folding. So watch out, this dura folding. So I will show you my cases. So what is the difference? What is the strong point of bifocal surgery? For the severe lumbar spinal stenosis, we just at first we think, oh, it is not a contraindication for endoscopic surgery. We need a microscopic surgery. But after a few years later, we tried several cases and we can access this laminar space safely and we can get the clear view. Then we can see the very, very clear structural margins and we can do every procedure safely. Then we can save the dura. So we can remove the very thick in a very narrow space. If the stenosis is the level at the high lumbar or low lumbar is not difficult. If there are many cases in the lumbar, but we can do every procedure at the same pattern. But in this case, if it's multi-level stenosis, we can do a decompression at every segment. Then we can solve the multi-level stenosis with bifocal surgery. How about the listhesis? Listhesis has two lesions, proximal stenosis and distal stenosis. Distal stenosis means just the same, the central spinal stenosis, ligament flavum hypertrophy and facet lower laminar spur. But at proximal lesion, at the same level of the foramen, in the listhesis, the upper lamina is going forward. So at the proximal portion, there is a bony stenosis. So we should try to remove the proximal bony stenosis. So using a chisel, we should try to remove the bony projection of the proximal area once more. Then we can decompress its proximal and distal in degenerative listhesis. And another character of the degenerative listhesis is it has the central and foraminal stenosis simultaneously, mostly. So at one approach, sometimes you can do two approaches for central and once more for foramen. But you stand on the opposite side and using a contralateral approach, we can decompress an executive root at one approach. That is a very, very useful technique in BAS. And I'll show you standard cases. In central approach, listhesis and stenosis, a 75-year female patient, and the listhesis grade 1, but it's very simple in BAS surgeon. So we decompress from a very, very good looking. So the pathology comes, there are proximal pathology, sublaminar spur, and near the foramen, SAP spur. and distally the ligament flavum and lower limb hypertrophy. So in the listhesis patient, we should think that proximal lesion and distal lesion. So if laterally, we're going to the interlaminar space deeper and remove the distal lamina hypertrophy and ligament flavum, and proximally upper lamina sublamina bony pulsation is resected, and supraorbital process spur also should be resected. And in sense, another strong point of bipolar surgery is magnification and illumination. So in the revision surgery, we can see the structures very, very clearly. So after, and another good point is the weak point of the bipolar surgery is the blood bleeding, blood surgical field. But in the revision surgery, all the vessels are already coagulated and already they're nearly dead because of scar tissue. So after shaving of, clearing of the scar tissue, we can get the clear view. So the revision surgery is very easy. And the margin and the structural margin is very clear. So we can do adhesiolysis very clearly without wider laminectomy or decompression. We can access to the interlaminar, the deeper spinal canal with the same dissection, and we can save the root after discectomy without wider laminectomy and fusion surgery. So the revision surgery is not difficult. It is a very special case. 2 times of recurrence of disc herniation, the patient underwent wider laminectomy already, but the second recurrence time, every surgeon recommend that don't do the surgery anymore, laminectomy anymore, and you need a fusion surgery. But the patient does not want fusion surgery because it's only late 58. So 1 year, he waited 1 year, but the symptom was aggravated and the right side of pain moved to the left side. So the patient cannot walk. So I did the bipolar decompression. But at first, the mass is too huge. So when I choose the right side approach, I can make a dura tear. So I access to the foramen underlying of the disc, and I remove the disc at the foramen first to decompress dura first, and then access to the left side and remove the remnant disc fragment. So the patient can walk well without fusion surgery. And the extraforaminal approach is a very unique and a very strong point in bipolar surgery. The foraminal lumbar disc herniation is very common, and yeah, but we can access even L5S1. We can access accessing is not difficult. After resecting of the supraorbital process, we can see the root, and under the root we can remove the disc fragment. It's already adhesion, and we can use the general instrument, the 2 or 3 millimeter Harrison punch, and the full spur performance can be done, and the root is saved. And sometimes the foramen has a very complicated area, so there's many hidden pathology. It is L5S1 foraminal stenosis, and I think at first it's a disc fragment, but I found it is a synovial cyst at the facet, so I can remove them. So the foraminal pathology in endoscopic surgeon, we have to discriminate all the pathology, structural pathology. It is not a simple foraminal stenosis. We have to see on the MRI the subpedicular kinking and the ligament flavum hypertrophy, supraarticular process hypertrophy. We have all of these lesions. After supraarticular process recession, the root is compressed by the subpedicular spur. We call it subpedicular kinking. So we have to remove subpedicular area cortical thickening, and then we can save the root freely. And during the flavectomy, foraminal flavectomy, I can find the cyst. So after removing that, the local circulation of the exhale root is recovered directly after decompression. So I use the chisel, the 60-degree bending, so I can access every lesion. So it is a corridor transept. So the local circulation is recovered immediately. Sometimes endoplated spur from the upper lamina impinged the root, but we cannot understand this lesion well. But in the endoscopic surgery, we definitely inspect, discriminate this structure pathology and remove this structure clearly. Okay, we can remove the endoplated spur. Even sometimes it is complicated. Some male patient underwent PLS fusion surgery in some of the other hospital, but the L5S1 decompression is not enough. And without cage, the fusion surgery is performed, but the creeping substance happens. So maybe 1 year later of the fusion surgery, the patient suffered from the left side pain. It is because of the incomplete recession of the supraarticular process. So even L5S1, even after fusion surgery, we can access to the foramen and we can remove the supraarticular process spur, and we save the patient without a revision big surgery. ASD is very common, upper and lower. So in ASD, in upper lumbar, mostly it is central and foraminal foraminal stenosis happen together. So, but extraforaminal approach at the upper lumbar, we can access, we can touch the midline of the dura. The corridor is very wide. So without central decompression, we can decompress the central area using foraminal approach. Every instrument can access at the midline. In the case, very complicated. 20 years ago, the patient have L4-5S1, a wider, nearly total laminectomy. So due to the iatrogenic instability, L3-4, severe stenosis, and listhesis, yeah, the central canal is not seen. The patient cannot walk and cannot sleep well. So I access the extraforaminal approach, left and right side 2 times, and then we decompress the central well. And the patient can walk well after only 2 weeks later without fusion surgery. Then everybody thinks that is the instability. Oh my God, you make a big trouble. No way, no way. The patient feels very comfortable. I only just removed the stone under the fin. And this is the final case, is the degenerative scoliosis and flat back for the stooping But this case is very simple. Most degenerative foraminal stenosis has only 2 or 3 focus of the lesion, foraminal stenosis or central one side of stenosis. So only decompression of the foramen can save the patient. So the biportal surgery is very easier than the microscopic surgery because the very wider view and we can discriminate the structure margin clearly. And after understanding of the structures and you have navigation, the endoscopic reference anatomy, and you can go everywhere in the spinal canal. So only one thing you should prepare is your first trial. Thank you. Thank you very much.
Okay, Doctor, that is a great task for you this night. I wish can to continue with the Doctora Elsa Gonzalez with the relevant best in the vision spine surgery. Please, I want to the speakers, please maintain the time of all the revisions, please. Thank you. We continue with the Doctora Elsa Gonzalez from Spain. Thank you. Thanks a lot, Doctor.
Well,
Perfect.
Well, good evening to all from Spain. Good morning, Dr. Choi and Dr. Kuhn. Good afternoon to all our colleagues in South America. My name. It's a bit late here where I am. Good evening to all. My name is Elsa Gonzalez. I work at Clínica Rosario in Ibiza. To let you know where I am, all those of you who are listening to us from several countries, we work in the island of Ibiza in the Mediterranean Sea. Many of you may have heard about it. Our hospital is the Rosario Polyclinic, where we perform most endoscopic procedures. It's the only private hospital on the island, and our team is the only one that treats spine pathology. We began our work in 2016 using BASE with Dr. Choi. In 2018, we attended the first international symposium, and last year we had the honor of organizing the second international symposium here in Ibiza. BES is a new and relatively young technique. Today, there are many surgeons who perform it in our hospitals and who try to solve most of lumbar pathology using this biportal technique. It has become more widespread, and it has many advantages as compared to traditional approaches. One of them is minimal injury produced to the muscles, to the paraspinal muscles. We can achieve wide decompression without fixation, and for us this has been of the greatest importance because we have diminished lumbar instrumentation in 90% of cases. The possibility of using also the floating technique, it gives us a panoramic view of the segment in which we're working, and this means that it offers less limitations and it is safer than uniportal endoscopic surgery. Regarding microdiscectomy, clinical results are quite similar, but the patient recovers much faster. Today, there are many publications about this technique, the advantages and the indications for which it can be used. The most important merits of BEST is higher magnification of the image that we can achieve, bright illumination also that can be achieved with the scope that allows us to distinguish the structures once we are in the field, and the possibility of using the floating technique, which offers greater versatility for our work. Indications: lumbar disc herniations in any location, lumbar stenosis, central and foraminal, thoracic and cervical approaches as well. And when we talk about the topic of this talk, we can say that it is very useful for revisions or reinterventions. In revision surgery, we can treat the disc hernias that have recurred, treated with endoscopy or with open surgery previously. It is very useful also in decompression when there is restenosis, and in ASD, where the patient has been instrumented. Basically, reinterventions in revision surgery. And revision surgery, the biggest limitation is the difficulty in visualizing the structures because of adhesions and scar tissue. There's a difficulty in differentiating the plane with regard to the fibrosis. This limitation in the visual field creates a bigger risk of damaging the dura or the root. And if we go back to the advantages of biportal surgery, well, those characteristics mean that precisely revision surgery becomes more advantageous. Regarding the instruments, as for any intervention in biportal endoscopic surgery, we're using a 0-degree endoscope. For coagulation, we're using a monopolar and bipolar coagulation system. And in irrigation, well, this is the coagulation system that we're using at the present time. We used to use the radio frequency previously and the specific instruments that have been designed for the technique. The patient is placed in prone position. As for any other intervention, we need to mark the level, and we prepare the surgical field the same way as we prepare it for any other endoscopic biportal surgery. It is very important to mark the incisions with scoping for a revision surgery. It's interesting to try to locate or localize the incisions in the most proximal areas to the midline, because that is where we will probably find less granulation tissue. The upper portal is placed in the lower edge of the superior lamina, and the lower portal in the superior border of the lower lamina. In the first few cases, it could be useful to use methylene blue to tint the disc, because it will help guide us when we have reached the interlaminar space area. But we are no longer using it. It was only during the first few cases. In revision surgery, in particular at the beginning, we need to be clear that we cannot lose our orientation. So we need to look for an anatomical landmark, which in most cases will be the facet joint, a bone structure that will enable us to follow the remnant of lamina and start to detach the scar tissue towards the midline. Many times we need to broaden the laminectomy from proximal to distal to widen the exposure. And when we come to the disc fragment that is extruded, we have to remove. Another benefit of the endoscopic surgery is doesn't force us to do retraction of the root, because and that is quite interesting. So once we have removed the disc fragment and we reach the nerve, if we find that the root is still quite adhered, it's not free, we need to think that there are adhesions in the basal area of the dura, so we need to do the adhesiolysis before we complete the procedure. As with any revision procedure, even if it is through BES, there can always be complications. There is a risk of tear of the dura and root nerve injury. This is a case of ours where there was a rupture of the dura, which we solved by placing 2 clips. And to conclude, biportal endoscopic surgery, it has become more widespread with excellent clinical and radiological results, and it has shown to have many advantages as compared to other approaches. It is very useful and particularly useful in revision surgery because of the lower risk of complications. Thank you very much. Thank you, Dr. Elsa. Excellent presentation. We're going to be talking not only of the biportal, but also the uniportal, and we will continue with Dr. Pedro Ginás from Spain as well, who will be speaking about neuronavigation in BES procedures, the future and technologies. Dr. Ginás, please be welcome. Yes, Dr. Ginás, you can now share your screen. We are seeing also Dr. Iglesias, Dr. Coop. We're very happy to have you all with us today. So let us continue now, Dr. Ginás. As it's worth mentioning that it's 3 a.m. in Spain. Dr. Iglesias has his babies and he has scheduled the surgery. So yeah, 3 a.m. in Spain. Dr. Ginás.
Bueno, como ya les ha presentado mi compañera, la doctora González,
colleague, Dr. González already presented.
Neurocirujano en Policlínica del Rosario.
I'm also a neurosurgeon at Clínica El Rosario in Ibiza.
Isla pequeña de un mar pequeñito, pero
a small island in a
una
small sea,
gran,
but
una gran historia detrás de
with
ella,
long history.
No sé si decir buenos días, buenas tardes,
I don't know whether
noches,
to say good morning, good evening, good afternoon, a little bit of all, but anyway, thank you very much, Dr. Torres, for your
desde luego la
invitation.
próxima reunión haremos horario europeo.
For our next meeting, we
voy a
will impose our European time.
I'm
going to be talking
una aplicación de una técnica que ya
the application of a technique that already exists
en columna, en cirugía de columna, que es la neuronavegación,
spine surgery, which is neuronavigation.
Como ya saben, pues para las fijaciones transpedicular
for transpedicular fixations.
Esta técnica desde hace 2 años la decidimos acoplar a la endoscopia biportal,
this technique to
con la
biportal
intención
endoscopic surgery
mejorar
in order
de
to
cierta manera la
improve
curva de aprendizaje,
the learning
disminuir el
curve
número de rayos
and
X
reduce
utilizados en cada uno de los
dose of
durante el acto quirúrgico
used during surgery
y bueno, para dar un poquito más de fiabilidad y optimizar los resultados.
To optimize
les describiré
outcomes.
un poquito en qué consiste la técnica. Como ya
I
saben,
want to explain the technique then. As
un
you
sistema de
know,
neuronavegación lo que hace es proporcionar
system
información
provides
veraz en tiempo real,
correct information in real
dando
time.
una
It
calidad de imagen
offers an
nítida
image
y
quality
sobre
which
todo,
is very sharp and clear,
limitando
and in
las
particular it
complicaciones
limits
que pueda haber,
the
por ejemplo, en el caso de
complications
fijaciones transpediculares
from
a la hora
transpedicular
de
fixations.
limitar el número de malposiciones de tornillos, por ejemplo,
Limiting malpositioning
o en
of
caso de
screws, for
resecciones
example,
tumorales,
or in
pues,
case of tumor resections.
Maximizar el grado de
Maximize
resección
the
tumoral
degree
en
of
este tipo
tumor
de
resection in
intervenciones.
this type of
Funciona como un
It works
GPS de un coche,
like a GPS in your car.
donde se produce una referenciación vía satélite
There's a satellite
de la
referencing
geolocalización del vehículo y
of the location of your car and your GPS. That's what the
trasladado
GPS does.
este mismo
And if
sistema
we
al
bring this same
quirófano,
system to the
pues
operating
digamos
room,
que la cámara o el receptor pues serían los satélites que geolocalizan la posición del paciente en la sala de
cameras are like
operaciones.
the satellites that are
Consta
placed in the
de
operating
varios
room.
elementos,
It consists of several elements,
generador de imágenes, en este caso
an
puede ser
image
el OARM,
generator,
un CEARM,
a
un
C-arm,
dispositivo, una cámara y
a camera,
un ordenador de a bordo con un
computer,
software específico y
with a
instrumental
specific software,
quirúrgico
and surgical instruments
específicamente diseñado para eso.
designed
Entonces,
specifically for
¿qué
this technique.
hacen los sistemas de
So what
navegación?
do navigation
Sobre
systems
todo
do?
nos dan
In
información
particular,
en
they
cuanto a
provide
la
information
planificación
about
quirúrgica
the
y el
surgical
abordaje
planning
quirúrgico
and the surgical
que vamos
approach
a realizar.
that we
Y
will
esto
be
es,
using.
se consigue
And
mediante la
this is
creación
achieved through the
de
creation
un
of
mapa de
a
puntos tridimensional donde
three-dimensional
se correlaciona
point map that correlates,
cada uno de esos puntos de la anatomía del
or
paciente
the anatomy of the patient is correlated
toda una serie de puntos
with a
obtenidos de las
series of
imágenes
dots or points
intraoperatorias
obtained
o
from the
preoperatorias
intraoperative
del
or
paciente.
preoperative images of the
Entonces,
patient.
se registra la posición del paciente
The
y de los
position of
instrumentos
the
quirúrgicos que
patient and of the
utilizamos
surgical instruments
dentro del
that we
propio paciente
use
en tiempo real.
inside the patient
Y
are
obtenemos
tracked in real
tanto
time,
trayectorias como
and
posición
we
en cada
can
momento
display
de
position
sobre
and
los instrumentos
trajectory
que
at
estamos
all
utilizando.
times.
Entonces, las partes del navegador, como ya sabrán la mayoría de
As
ustedes,
most of you
pues
know,
constan de un monitor con un
the
ordenador,
navigation
un
system has
localizador, que
a
en este caso
monitor,
es
a
la
computer, a
cámara,
localizer,
software
in this case a
específico,
camera,
en nuestro caso de
specific
columna,
software, in this
y
case for the
un marco de
spine,
referencia del paciente,
and
donde
a
indicaremos
reference frame
que,
for the patient.
es decir, el detector, la cámara,
The camera
va a generar el campo tridimensional que es la anatomía del
generates
paciente
the 3D
referenciado respecto a
field
los 4 puntos
referenced
de este
in
marco
regards
de referencia.
to
Los
the
instrumentos
4 points in the
específicos
reference
que
frame.
se podrán ir añadiendo a lo
These
largo
are
de la
the specific
intervención
instruments
y las imágenes obtenidas del paciente
and
durante la
images
cirugía o
obtained
previamente,
during
si
surgery or
si hemos
before
hecho,
the
por ejemplo, un
surgery.
TAC con reconstrucción tridimensional, etcétera. Entonces, la cámara lo que hace es
So
mandar
the
una radiación
camera
infrarroja
sends an
que es reflejada
infrared
por
ray that is
las bolas
reflected from the
de los marcos de
spheres
referencia
of the
y eso es
reference
detectado
frame,
por la cámara,
and that is
procesado
picked
por
up
el software
by the
específico
camera,
y se
processed by the
reconstruye
software,
pues
and
cada
then
uno
a
de los puntos de
reconstruction
la
is
anatomía
made
del
of
paciente
each of the points
respecto a
of
las
the
imágenes
patient's
obtenidas.
anatomy in
Lo
relation
más
to the
importante
images
para
obtained. And the
conseguir
most important
que
thing
la
to
navegación
achieve
sea sobre
or
todo
to
segura y
make
eficiente
sure that
es
navigation
que
is
el
safe and
marco
efficient,
de
what is
referencia del
needed
paciente
is
y el
to
propio
make sure
paciente
that the
no deben moverse
frame of reference
durante
and the
toda la
patient should
intervención
not
quirúrgica.
move
Si eso
during the
sucede,
entire
se debe
operation.
parar
If there is
y
movement,
reiniciar todo el
we need to
proceso.
stop and restart the entire process.
En cuanto al software, lo que
In
se
terms
hace
of
es
the software, what
introducir toda
we
una serie de parámetros
enter
de cirujanos, otro
the
tipo de
parameters
procedimiento, se chequea
about the
que
procedure.
todos los diferentes dispositivos
We check
estén
that
bien
all the
conectados,
devices are well connected.
se verifican cada uno de los instrumentos
We
que se van a
verify
utilizar, así
each of
como
the
los
instruments
marcos
that
de
will be
referencia
used, as well
del
as the
paciente y del
reference frames of the
SEAN,
patient.
y
Uh,
se procede
and
a la obtención de las imágenes. Entonces,
the images are
podemos
acquired.
confirmar en cada
We
momento
can
el
confirm at
punto
every
exacto de nuestro
moment
instrumento en el interior del paciente. ¿Vale?
exact
Entonces, ¿cómo
location
lo
of our
hacemos
instrument
nosotros en
inside the
Vista?
patient.
Pues
So how do we do it in
colocamos al
Vista?
paciente en
We
decúbito prono,
place
como
the
cualquier
position
intervención
in
de
prone. We
columna
place
estándar.
the patient in prone position
Lo
as
que
for any
hacemos es
standard
adaptar
spine operation. We adapt
el marco de referencia del
the
paciente
reference
a
frame,
la
the
mesa
patient's reference
quirúrgica
frame, to
mediante
the surgical table.
una barra articulada
attach it through
de
an
tal forma que
articulated
sobre todo
bar
nos
in such a
aseguramos
way
que
that
lo que he dicho antes, ni el paciente ni este
we
marco
can
de
make sure
referencia
that the
se vayan a
frame
mover durante
will
toda la
not move
intervención.
and that the
Si eso
patient will not
sucediera, hay
move
que
either during the
iniciar
entire
otra vez todo el
intervention, because if
procedimiento.
there is any movement, we need to restart
El
again.
fluoroscopio lleva
The
su
C-arm
propio marco de referencia,
has its
de tal
own
forma que cuando se
reference
obtienen las
frame.
radiografías
So
en
when
proyección AP y
the
proyección
AP
lateral,
films and the
ese
lateral
marco de
films are
referencia del
required,
fluoroscopio
the
se correlaciona
fluoroscope frame of reference
tridimensionalmente con
is
el marco de referencia del
correlated
paciente, de tal
in a
manera
3D
que
way with the
se
patient's
le dice le
reference
da la
frame.
información al
So
navegador
information is
de
provided to the navigator
cada punto de la imagen radiológica
that
corresponde
each
a un
point
punto
in
anatómico del paciente.
X-ray image corresponds
Este es
to an
otro,
anatomical point in the
pues
patient.
se puede ver perfectamente en la imagen
And
los puntos
we can see
de
here
referencia
the
del
points
marco
of reference
del
of
fluoroscopio
the
y las
fluoroscope
vértebras del paciente
reference frame
en su
and
interior. Entonces
the
ese es
patient's
el
vertebrae
campo
inside.
quirúrgico en el
And
que
that
vamos
is
a
the
trabajar.
surgical field where we're going to
¿Vale?
work.
Entonces, lo más importante
The
es
most
que la
important
cámara
thing then is that the
esté
camera
en línea de visión directa
is
con cada
in
uno de
direct line of
de
vision with
los marcos de referencia.
each of the
Si no se
reference
detecta
frames.
bien, no se puede navegar.
If detection is not good, navigation
Una
will
vez
not be
obtenidas las
possible.
imágenes
Once
correctas,
the right
entonces
images are
procedemos al
required,
marcaje
then
de las
we
incisiones
proceed
en
to
función del abordaje
mark
que querramos hacer.
the incisions
En este
based on the
caso,
approach that we
pues
are going to
haríamos un
use. In
abordaje
this case, we
transforaminal
are
L3,
going to select
o sea,
a transforaminal approach,
L3-4
L3,
izquierdo.
L4, left on the left.
Hay que recordar que las
We need
imágenes
to remember
radiológicas
that
son
radiological
imágenes
images
anatómicas.
are
Es
anatomical.
decir, el paciente está en decúbito prono,
The patient is
luego
in
lo que
prone
vemos a la derecha
position,
de
so
la
what we see to
imagen
the
es la
right
derecha del
of the
paciente y lo
image
que vemos a la
is the
izquierda de la
patient's
izquierda.
right side, and what we see to the left is the patient's left side.
Este es un detalle del campo
This
quirúrgico
is how the surgical
como nos
field
queda
looks
para,
like,
es decir, preparamos
how it is
todos los
made
paños,
ready.
todo el campo estéril y lo
We
que es el
have
marco de referencia
the
del
sterile
paciente no lo
field, and the
sustituimos por uno estéril,
patient's
sino que lo que hacemos es colocar
reference
una
frame
funda
is not
estéril encima,
replaced. We
precisamente
just
por lo que he
placed
dicho
a
antes,
sterile
no
cover on
mover
top,
este marco.
because the idea is never to move that frame.
En esta imagen se ve bien
On
el
this
artroscopio
image, you can
con
see
su
the
propio
scope
marco de
with its
referencia,
own
de tal forma que
reference
cuando lo
frame.
introduzcamos
So
en el
when
interior
we
del
introduce
paciente,
it
sabremos
inside the
en todo
patient,
momento
we
dónde
will
tenemos
know
la
at all
punta del
times
artro,
where the
lo
tip
cual
of the scope
podemos,
is.
no hay posibilidad
So
de
there is no
confusión ni de
possibility
espacio ni de ubicación.
of
Este es un detalle
confusion. This
del
is
quirófano,
an image of the
el
operating
instrumental que
room.
utilizamos es
You
un
can see
instrumental general,
the
hay unos
equipment, the
sistemas
instruments,
de cucharillas que son específicos para esta técnica, así
specific
como
instruments for this technique,
escoplos, discotomos,
chisels,
pinzas Harrison,
carries
etcétera,
and
discotomos,
punches,
¿vale? Delante tenemos los monitores y luego en un
monitors,
lateral solemos colocar el monitor del navegador.
and the navigation
Estos son unos
monitor.
vídeos en vivo, en este caso es una aorta
Live
interlaminar,
videos. This is an
y si se
interlaminar
fijan en el
approach.
monitor del navegador
If you look
se
at
ve
the
cómo la punta
navigator
se va moviendo
monitor,
al
you
mismo
can
tiempo que
see how the tip
mueve
moves
la imagen
as
de la escopia.
as in this as you see the movement in the scope image.
Esta es una imagen específica de lo que es la navegación. En este caso estaríamos en el margen inferior de la lámina.
Here we see on the
Esto es
navigator monitor
otro
what is
detalle,
happening with the tip of the instrument.
utilizando. Se pueden utilizar los instrumentos que uno quiera. Ahí de hecho se
You can
pueden
use all the instruments that you need to use.
referenciar cualquiera de ellos.
You
Nosotros
can
por
reference any
comodidad
instrument.
referenciamos solo
We reference only
el endoscopio
the scope
porque es muy fácil
because
moverse
it's easy
y llegar a contactar prácticamente con
to move
cualquiera
and
de
come
punto de
contact with
la anatomía
any
expuesta. Entonces,
point
pero
of the
vamos,
exposed
si uno quiere,
anatomy.
referenciar
But you can
la
reference other
fresa
instruments, the burr
o el periostotomo o lo que sea, puede hacerse sin
or
ningún
the
tipo de problema.
osteotomy, or you can do it.
Este es un abordaje extraforaminal.
This is an extraforaminal approach.
Se va viendo cómo se va moviendo la punta del endoscopio
You can
en
see
tiempo
how
real.
the tip of the scope moves in real
Vamos
time.
viendo que conforme se mueve
We
hacia un
see
lado u otro,
as it moves to one side or
vamos
the other,
identificando diferentes estructuras.
we
Esto, por ejemplo, a
identify
raíz de la
different
charla de la
structures.
doctora González en cirugías de revisión, donde la
In
anatomía
revision surgery, where
está
the
sustituida por
anatomy
tejido
is
fibrótico,
substituted by
te da una gran
fibrotic tissue,
orientación.
it gives you
Sabes
great
perfectamente
orientation. You know
lo que
perfectly
te vas a
well
encontrar debajo
what
de
you
ese
will
tejido
find
superficial,
under
sencillamente
the scar tissue.
navegando. Es como si estuvieses haciendo rayos X permanentemente.
It's as
Entonces,
if you were
en
doing
cuanto a las
X-rays
conclusiones
permanently.
respecto
In
a
terms of
la
conclusions
neuronavegación asociada a la endoscopia
regarding
biportal de columna,
neuronavigation associated with
es una
BES,
técnica
it is a
segura,
safe
sencilla
technique,
y
simple, and
que sirve de ayuda sobre todo
it helps
en la curva de
in
aprendizaje,
particular for the learning
porque
curve,
disminuye
because
muchísimo el número de
it
rayos X que
reduces
utilizas.
the amount of
También
X-rays
en
that
cirugías
you
donde
are
hay
using. Also,
mucha
in
deformidad,
surgeries
cirugías de
with
escoliosis
a lot
o
of deformities,
cirugías
scoliosis,
casos
or
de revisión
surgeries,
quirúrgica donde hay mucha fibrosis, mucho tejido fibrótico
revision
que
surgeries
impide
with a
ver.
lot of fibrous tissue
Luego tiene otra principal ventaja y es que
where you cannot
el
see well.
posicionamiento del instrumental
It offers
puede
the
testearse
advantage
durante
of
todo el acto quirúrgico.
allowing you to test the positioning of the instruments
Evita
throughout the
la
entire
confusión de
surgery.
espacio y
It
esto
avoids
sucede y
confusions
no
of
solo al
space,
principio
and
en la
this
curva de aprendizaje,
happens
sucede
not only at the beginning
en
of the
muchas
learning curve,
intervenciones
it
donde
happens in many interventions where
pierdes
you
el
get
nivel
lost,
o
where
crees que
you
estás
lose your
en
level,
un
you
lado del
lose your
canal
orientation, you
y
believe
cruzas
you're
al
on
otro
one
lado.
side of the
Puede
canal and you're
suceder
actually crossing to
suceder
the other side.
en muchas
It may
ocasiones. Con
happen
esto se
many times.
minimizan
So with
la
this,
aparición de errores.
with
Ahora, eso
navigation,
sí,
you minimize
lo más
that
importante es
situation,
que
and the most
no
important thing
deben,
is that
no deben moverse ni el marco de referencia del paciente ni el propio
the
paciente en
patient
ningún momento.
reference
Si
frame
esto es
or the
así,
patient himself
tiene que
should
reiniciar
never
desde el
move,
principio,
because if there
no
is
se
movement, you
produce
need to
propiedad.
restart all over.
Entonces, bueno, otra parte
Well,
de la charla
another
era
part of the talk had to
cuáles
do with
posibles tecnologías futuras aplicadas
future
a la endoscopia
technologies that
biportal de
could be
columna.
applied to biportal
Y bueno,
endoscopic spine
mi
surgery.
apuesta
And
no es muy futurista, sino
I'm
más
not
bien
very futuristic in what
realista.
I
Hoy en día,
bring you.
yo
It's
creo
more
que
realistic. I think that
las principales tecnologías que se pueden aplicar a la
technologies
endoscopia
that can be
van a
applied to
ir
endoscopy
de la mano de la robótica.
will
Como por
be
ejemplo el Da Vinci
working
o que
hand in
puedan
hand
aparecer
with
en el mercado,
robotics,
o que incluso que ya
with
estén,
the
podrían
Da
acoplarse a esta
Vinci,
técnica y
for
convertirla en una
example,
cirugía, si no
the
100%
technique
robotizada,
could
parcialmente.
become a
Luego,
partially
la
robotized
creación de modelos
surgery.
de imagen
Also, the
tridimensionales que
creation of
puedas
3D models,
manipular,
images that you
creo
can
que es
manipulate.
otro
I
de los
think that
factores a
that
tener en
is
cuenta.
another thing to consider.
Quirófanos interactivos
Interactive operating rooms,
donde bueno, toda esta información extra
where
pueda
you can benefit from
aportar
additional information
conocimiento, facilitar la toma de decisiones o el
to help you with your decision making,
información con otros
or
colegas,
help you
compañeros de
share
un centro de ciencia,
information with
realidad
other
aumentada,
colleagues.
que es otra
Augmented reality is another
posibilidad. Y
possibility,
todo esto, bueno,
and
podría hacer incluso
all this
llegar a alguno de los mentores nuestros, pues podrían incluso llegar a
could
operar desde
help us work
sitios
with
un poco más,
one of our mentors
¿no?
and
quirófano.
operate from better places than the operating room itself.
Para concluir,
To conclude
decirles
then, let me tell you
que
that
al ser centro formador, en esta técnica de la mano de Dr. Choi
We have
y
been
del
working
resto
with
de su
Dr.
equipo,
Choi
pues
and
les
other
invitamos a quien
people in
quiera
his
que pueda
team.
venir a
Ours is a
Ibiza
training
presencialmente
center.
con nosotros.
Those
Muchas
of
gracias.
you who would wish to visit us, you will be more than welcome. Thank you. Well, thank you, Dr. Ginas, for your excellent discussion, a very interesting one. And this is incentive to move ahead. After seeing this technique, I think it's very encouraging because you diminish radiation. So now we have with us Dr. Roberto Cantu, spine surgery. He was a pioneer of uniportal endoscopic transforaminal surgery in Monterrey, in Mexico. He has been a president of the Orthopedic Society of Mexico, and he is a very important surgeon. His son is also a spine surgeon, and it is a pleasure to have you, Dr. Cantu, who will be speaking about the relevance of endoscopic surgery in pandemics, in particular in this pandemic. Thank you, Dr. Cantu, for sharing with us. Can you hear me? Yes, we can hear you perfectly. Our special greeting also to Dr. Elsa Pedro for staying with us at the wee hours of your morning. Yes, Dr. Cantu, go ahead. We can see you and we can hear you. Thank you very much, in particular to those in Europe who are past their sleeping time. Let us not forget that we're living in the midst of a pandemic and that we are not performing all the surgeries that we usually perform. So what is the relevance of endoscopic spine surgery, whether biportal or uniportal, at this time of the pandemic? We all know we have received a lot of information about the pandemic. We know that it has affected all the countries in the world and that there are close to 5 million infected patients in the world and close to 300,000 deaths. So it is something that is becoming more widespread. It is not over yet. And we know that it affects many organs and it affects the patient and it can affect us as surgeons. And we need to select the patients and do all the necessary workup and testing, determine risk factors. Many algorithms have been designed with different guidelines, all of them with the same purpose. Safety for healthcare staff and safety for the patients. We know that many healthcare workers have been affected. Some of them have died, and we need to be taking care of ourselves as well. We are looking at the international guidelines, the American Spine Society and other guidelines, and we assess each case individually because we need to determine the patient's needs and we need to determine if we have the availability and the capability to do this surgery. This is from the American College of Surgeons. It makes a distinction between phase 2 and phase 3. And it mentions the same things that were already mentioned. And what from the North American Spine Society, we follow guidelines. And as you mentioned, emergent and urgent cases. We have to solve them. We need to find a way to take these patients to surgery. If the hospitals are saturated, we need to find a way to solve the problems for these patients who cannot wait. For example, progressive or severe neurologic deficit due to neurologic compression, spinal instability, epidural abscesses, postoperative infections, and in the urgent category, myelopathy with stenosis, ascites, significant neurologic deficit, and intractable pain that will not respond to other measures. And elective procedures, many times we can do them, but always taking into consideration the type of anesthesia that we use in many of the procedures. Specifically, anesthesia that we use for the types of surgery that we do is local in 80% of cases, 10% is regional anesthesia, and 10% is general anesthesia. There are many procedures that can be done under local anesthesia. This is a very complete guideline from the plastic and cosmetic surgery, showing the algorithm for high risk, medium risk, and low risk, and showing what needs to be done. And this other algorithm approved by the American Academy of Orthopedic Surgery. The red is what shouldn't be done, green is what can be done. And well, this is yet another algorithm. I will not go into the details, but it's just to mention it. And finally, another guideline showing stages 1, 2, and 3. And we need to take into consideration also the facility, the hospital. Is the hospital able to maintain staffing levels to support the procedures that we perform in normal conditions for stage 1, for stage 2? Many elective surgeries are allowed using an algorithm, and others are not allowed. And in stage 3, when the hospitals are full of these patients, then elective surgery is not permitted because of the danger of contagion. But in a city like ours, where there are hospitals that are not admitting COVID cases, there is usually a way to proceed. In Monterrey, we have a population of 5 million, and the incidence at present is low, but it continues to increase. The measures of confinement have been relaxed, and cases of infection are increasing, but we still have a good hospital capacity to operate many times normally. But protocols test no more than 72 hours, the PCR test. And here I present some cases that we have been operating. This first clinical case is an extruded hernia, L4, L5, where patient was in great pain. On the left, we can see neurological deficit on the left side, and this was as a result of a fall during exercise. And because of the neurological deficit, we couldn't wait for medical treatment. So discectomy was done totally through the endoscopic approach. The hernia, extruded hernia, we see here, and the sequestration. So we started through a transforaminal approach. We remove disc that is close to the herniation, and then we go to the dural sac, and then we go to an interlaminar approach for an L4, L5 myectomy, uniportal approach in this case. We use the 4 millimeter working channel. in this foraminoscope. And here we are resecting the ligamentum flavum. We can see the epidural fat, and we almost always stain the disc when we do the transforaminal approach. We use indigo carmine, and lately we have been using methylene blue as well. So we reach the disc fragment that was extruded, and we finished in this case with an 8mm incision, an 8mm scope with a working channel, and we can see the extruded disc very easily. To the left, the exiting root, and it was solved correctly. The patient stayed in the hospital only for 1 day. This is another example, another clinical case. 45-year-old male, sedentary, body mass index of 29, and after he lifted a heavy object, he had an extruded disc that went to the right. He lost strength with a positive laseg, and we see how the hernia is here extruded to the right side, and the fragment hernia encompasses even down to the disc of L5. We started with a transforaminal approach, L4, L5 on the right side, and we need to mention that the scope here has a working channel of 7.1 millimeter, and we're using a high-speed burr, very sharp, and it fits through the working channel, so we can very quickly resect it. In this case, we did the right L4, L5 transforaminal, and the lamina was resected the other way around. We started at L5, and we did a hemilaminectomy up to the level of L4. Kerrison punch here that fits through the scope, and it allows us to work This case was also done under local anesthesia. There's some bleeding. We can see the dural sac. And later we'll see the disc. This procedure lasted 35 minutes for the laminectomy. This I call biportal, but not to work simultaneously through the two portals. But through one portal, we decompress the L4 disc, and through the other portal, we correct the extrusion. So here we see the dural sac completely released, the root completely released, and in the circle here on the image, we see the complete laminectomy of L5 on the right side. This was the last thing that we resected. Another case, just the last one. Another 70-year-old male patient with lumbar stenosis. We see the MRI on the left with narrowing of the bone tissue and a hypertrophied ligamentum flavum. He had intense right sciatic pain, loss of strength, progressive loss of strength of the right limb, claudication. So we brought him to surgery. To the left, we can see the CT scan. We can see facet hypertrophy, foraminal stenosis, and in the lower panels, the decompression. And on the right side, also significant stenosis, and here we performed hemilaminectomy on the right side also. And we went over the top to the other side and we decompressed the recess and we freed the root. We removed all the laminas on the right side of L4, and we also removed some 6 millimeters of the L5 lamina. The course of this patient was very good, excellent. He went back to work very soon. He had paresis initially, but he recovered fully. So these are cases that we have had to perform. The surgical team to the left, Dr. Roberto Cantú Longoria. We've been working with him for a long time now. To my left, this was to your left, with Dr. Roberto Cantú. Then the pictures in the center panel, Dr. Daniel Pavón. To the right, Dr. Cantú Longoria, a fellow, Dr. Lucio. And my anesthetist, Dr. Manuel, with whom we have worked many cases. He provides local anesthesia and he always talks to the patient. And that is what I wanted to share with you. I didn't want to take more of your time. Thank you. Thank you, Dr. Cantú. Very kind for your talk. It was an excellent talk. Endoscopic surgery of the uniportal type doesn't exclude, or it's not exclusive, and they can work together, the biportal and the uniportal. You're doing surgery with your family, your son. And now we will hear from Dr. Jorge Felipe Ramirez. He is a very important person in uniportal surgery in Latin America, and he will be talking about his experience in Colombia. His daughter is also a spine surgeon, and he works with her, together with her. So it's an honor to have Dr. Ramirez with us. Yes. One of the things that he said once that it was that operating a disc open was a crime. We have changed, and I'm very happy to see you all discussing this type of endoscopic surgery for disc surgery. So, Dr. Ramirez. Yeah, good evening. Thank you, Dr. Torres, for giving me this opportunity. Today I'm going to be referring to the Foraminal Approach, and in particular, because of the lack of time, I'm going to be talking about the experience in Colombia. This approach, Foraminal Approach, is 95% of my clinical practice, of my endoscopic clinical practice. The advantage is it provides clear view, less pain and bleeding. It is an outpatient procedure. It doesn't create peridural fibrosis, less damage to the annulus, and less risk of instability. Peridural fibrosis is the cause of 24% of failed surgery in the spine, and it is a natural consequence of open surgery. In 1998 in England, Martin Knight published the first paper on endoscopic foraminoplasty using laser. Later, in Germany, Rutten published in Spine and showed that the clinical results of endoscopy are the same as in microsurgical techniques. These two papers published in Neurospine and Pain Physician in 2016 shows that lengths of stay in the hospital and bleeding are in favor of endoscopic surgery. This Cochrane review and this journal of surgery in 2014 and in 2016 show better results in terms of bleeding, surgical time, infection with endoscopy as compared to microscopic surgery. These publications in 2014 and 2015 in neurosurgery show that microdiscectomy produces a high risk of instability, and endoscopy has a lower cost and offers more benefit. These publications of the group, my group, Ramirez, and my collaborators, show more than 12 papers published in indexed journals. Regarding the anatomy, we can see the dural sac, the transient nerve, the fibrous annulus, and the emergent nerve. The safety triangle, as described by Cambin, shows the dural sac, the intervertebral disc, and the emergent nerve. The nerve root, as we see to the left, is between 9 and 6 o'clock. On the right is between 3 and 6. This book, which I co-authored, which was published in 2018, refers to a very important thing, which is experience-based medicine, with several chapters about the transforaminal approach. So let me talk about my experience, or our experience in Colombia. Since 1996 and up to 2018, we have operated 2,735 patients with a follow-up of 23 years. The important thing here is that for MACNAB, we have 88% results between excellent and improved, and visual analog scale that goes from 8/10 to 2/10 after surgery. Now the complications. In our experience, 49, which is 1.7%, and the highest number has to do with radiculitis, transient motor deficit in 5 patients, bacterial ascites in 8 patients, and end plate injury in 8 patients. In terms of the rate of reoperations, 84 patients, that is 2.3% of our population, divided into pathologies that are different from the disc, more lumbar stenosis, 77%, and they were solved with endoscopic surgery, and 23% with open surgery. And in terms of reoperations, because of incomplete disc removal, 76 patients, that is 2.1%, and 70% of those cases were solved with open surgery, and 30% combining foraminal and interlaminar endoscopic approach. Now, our experience with the clinical cases that I will show. This is an 11-year-old girl who was a cheerleader. She fell from a height of 2 meters, and we can see dynamic x-rays and MRI showing an extruded hernia at L4, L5 to the left side. She underwent 2 blocks, and then we performed an endoscopic procedure at L4, L5 on the left side with local anesthesia, sedation, and we can see here the amount of disc that we resected. 1 centimeter. This is the endoscopic image of the procedure. The next case is a failed back syndrome, a patient who 6 months previously had open surgery at the L3, L4 level with no improvement. The MRI shows L3, L4 hernia, extruded hernia on the right side, migrated caudally. we proposed the endoscopic foraminoplasty of L3, L4 under regional selective anesthesia. Here we see the procedure. We can see on the discography the use of manual burrs. We went in now with the scope. We see the fragment as the free remove fragment that had been left behind after the first procedure, and the free root and the amount of disc that was removed. This is another case. A 99-year-old patient with all the comorbidities that may be found at that age. The MRI shows compression by disc and bone at L2, L3 on the right side. We proposed to use selective regional anesthesia and to perform endoscopic foraminoplasty at this level, L2, L3, and we can see here the approach going in with the tree fines, and we proceeded to perform endoscopic discectomy, the use of RF to achieve good cauterization, and finally the free root and the amount of disc that was obtained. And finally here we see immediately after the procedure assessing the quadriceps, and 3 days after surgery. As we can see, she's 99 years old and she looks perfectly well. This case of foraminal stenosis, a patient on plain x-rays, dynamic x-rays, showed no instability, but scoliosis and MRI compression at the level of L2, L3 on the right side. And we performed endoscopic foraminoplasty at that level, and we can see here the compression with tree fines. It was completely closed, and the use of a shaver, diamond tip, and we can see the movement here. That's why of the legs. That's why it's called selective regional anesthesia. And finally, we can see the amount of bone disc that we removed and the completely freed root. This is a very interesting case, a stenosis, foraminal stenosis, bilateral. And we look at the X-ray and we see a grade 2 lysis. It is stable at the level of L5S1, and MRI that shows bilateral compression greater towards the right side. So we proposed L5S1 foraminoplasty, bilateral, starting on the more symptomatic side, the right side, and then the left side. And here we see the procedure, discography. We went in with a manual burr, endoscopy, and the use of endoscopic tree fines, endoscopic discectomy, and final decompression. After we did the right side, we went to the left side using the foraminal technique, and here we see the disc resection and the root completely freed. And next day, this is the patient. She is well, her 2 incisions because of the bilateral procedure. This is a very interesting case because it is a hernia due to flexion instability. In a 79-year-old patient, you can see the dynamic x-rays and you can see instability in flexion. The MRI shows left compression. So we placed an intersomatic cage, endoscopic assisted standalone lift and regional anesthesia. So here we see the procedure. We started with the diamond tip burr. We prepared the bed for the placement of the cage. And here we see the confirmation, endoscopic confirmation of cage placement. The patient also had severe lumbar pain, so we performed rhizolysis using the technique that we described, the 360-degree technique, and a CT scan after 3 months, and radiographs and MRI after 1 year. ASD, the patient had a history of 4 prior surgeries, the L3, L5 for decompression with instrumentation. We see the X-rays and the MRI showing compression in the adjacent segment, the L5S1 to the right, and also facet arthrosis. We proposed endoscopic foraminoplasty, L5S1, with rhizolysis. And here we can see the procedure. We started the approach, discography, manual percutaneous burst, and we performed the discectomy endoscopically. And we can see facetectomy here using frontal bursts, diamond bursts. The Kerrison punch and the root free, the amount of bone and disc that was removed, and finally we supplemented with facet rhizolysis in 360 degrees. And here we see the patient 1 week after surgery. As we say in Colombia, a fine gentleman with no pain, comparing the X-ray with the image and the transforaminal scar. And the last case to finish, an athlete, a high performance athlete, a weightlifter, a 32-year-old who showed on the MRI this extruded disc. It's a left L4, L5, a contained disc in L5S1 and facet arthrosis L4S1. So the surgical plan was to perform endoscopic foraminoplasty for 5 left with thermodiscoplasty using RF in L5S1 with facet rhizolysis L4, L5 and the placement of an interspinous percutaneous spacer at that level so that he could compete 7 months later in the Olympic Games. And here we see the surgical procedure. We are starting with the endoscopic discectomy at L4, L5 on the left side, where we can see the amount of disc that was removed and the root completely freed, the left L5 root, the root of L5. And then we proceeded to do thermodiscoplastic using radiofrequency at the L5S1 level. Facet rhizolysis using the technique that was published in Pain Physician, and finally the placement of this interspinous spacer also produced here in Colombia at the level of L4, L5. As soon as we finished and then we see him 7 months later competing in the Olympic Games in Rio de Janeiro, and he got the gold medal for our country. He came back to Colombia. We performed these dynamic X-rays. We see the spacer in place, the MRI, and he was very grateful. And for 3 minutes, he gave me his medal. And here with my daughter, Carolina, who is part of our team, and with Dr. Rugeles here, and everybody very satisfied because of that wonderful triumph of our athlete. Thank you very much. And this is what I wanted to show you of our experience here in Colombia with transforaminal surgery. Dr. Jorge, thank you very much for your talk. It is really a pleasure to listen to you now. We will continue with Dr. Nicolas Prada. Nicolas Prada also trained in Korea. In Korea, they are also pioneers. We have important doctors with us. And Dr. Prada will be talking about the uniportal technique for disc hernias, disc herniations, and technical uses. Thank you, Dr. Prada. Dr. Prada comes from a city close to Bogota, a very lovely city. We hope that you can come and visit our beautiful country. It's a beautiful place. Dr. Prada comes from the city of Bucaramanga, a wonderful city. Dr. Cantu, I forgot to send our greetings to Dr. Mirelis, neurosurgeon, who has a very severe condition. I pray that he will recover. He invited us in last December to Guanajuato, but now we hope that he will recover. Dr. Nicolas Prada. So now you can go ahead with your talk. Thank you. Thank you, Dr. Torres, for this invitation, and to the organizing committee of our Orthopedic Society. Good evening, good afternoon, good morning to all the participants. I'm going to be talking about the technical considerations to take into account when we decide to perform a discectomy in the extraforaminal space. So the most important thing for this discectomy is to make the diagnosis. These are hernias that are missed many times, and if we don't consider them, they will not be diagnosed. And these are patients who are limited by pain for a long time, and in the end, they present neurological deficit because of compression. It's a zone that surgeons or general practitioners are not always trained to assess and analyze on the images. So the first thing is the diagnosis, and the second thing, I think that the most important player is the triangle of Cambin, because through it and around it is where we will find the pathology and where we will need to be very clear about the structures so that we can actually achieve the safest release. Initially described by Dr. Cambin and published in 1991 as an endoscopic technique, it helps us gain access to herniations outside the canal or in the foraminal region. And then Dr. Anthony Young, with a series of studies that he conducted based on his experience, also described this zone as the hidden zone, and it lodges residual fragments or is associated with failed back syndromes because of insufficient decompressions during arthrodesis. So what's important about the triangle, we need to know that it consists of bony and soft tissue. The bone tissue forms the roof, the superior, the ascending facets, and the base, the end plate of the lower vertebra. In the upper portion, we will have the exiting root, and if we go deeper in our approach, then the descending root. It's important to be well oriented in that area in order to do the decompression safely. And if we don't have adequate access, or if there is a lot of tissue that limits access to this zone, we can use the different elements that we've seen in the other presentations to expand the space and perform a foraminoplasty and remove the roof of the facet. Very important thing to consider in these herniations, the location, because depending on the location of the hernia, both the affected level and the lumbar level, and also in the relationship with the canal, the angle of attack will vary. Not all of them are approached in the same way. The higher the level, the angle will be more vertical or more steeper. And the reason for this is the retroperitoneal organs that can be injured. And therefore, it is very important to do preoperative planning for this approach. Regarding generalities, the important thing to bear in mind, the retroperitoneum, in particular the high levels, L2, L3, in particular, facet orientation will help us change the angle of attack on these hernias. Generally, we do it directly, frontally, and it is not necessary to remove tissue. It's very important to assess the anatomy and the content of the foramen in the MRI in order to determine the disc height and the relationship of disc height with the position of the root as it exits the foramen and the vessel that accompanies it, in this case, the root artery, to avoid massive bleeding during the procedure, which might prevent us from achieving our objective of decompressing. This is a hypervascularized area, as was mentioned in the first talk. The different arteries were already mentioned. That's why it's very important to apply good hemostasis from the very beginning to be able to identify the structures. And bear in mind that when you manipulate that area, the ganglion is close and there could be some dysesthesias after surgery. But after 2 or 3 weeks, the patients recover. Muscle planes that we will go through during exposure position of the cannula and the sheath are the same as the transforaminal approach. It's just soft tissue. We need to remember that there are no nerve structures there, and the only structure that we need to be careful with when we come close to the triangle is the emerging root only, the exiting root only. It's important to identify the location of the hernia in order to diminish manipulation of the sac. Usually extraforaminal hernias are lodged in rejecting the root superior and lateral, and so this increases our working space, making the approach very safe. According to the type of compression, if it's a mixed compression and stenosis due to degenerative processes, so we supplement with foraminoplasty, and always bear in mind that this procedure is important for patients who have had insufficient open decompressions or residual pain as associated with the hidden McNabb zone. It's important to know the location of the hernia, because depending on the location and the relationship to the anatomy, that is where we are going to place the working elements, as we will see later on. We can see that the hernia in blue is from the midline of the pedicle towards lateral, that this hernia is not in the canal, therefore we don't need to go into the canal to decompress and remove. As I mentioned previously, it's important to bear in mind the retroperitoneum, because it will change our angle of approach and attack to avoid injuring structures. Here we see the kidneys. And so we need to make measurements and take that structure into consideration and avoid injuring it. And facet orientation is important because as we go to lower lumbar levels, they become more coronal. So we need to consider this, because if we want to do some leverage or lever movement with the facet, we are not going to be fighting against the bone. As part of the planning, we need to know the diameter of the foramen. We do not always have to measure it because the cannulas allow us a lot of space to work there. But if it's a narrow foramen, we need to widen it to avoid injuring the nerve and the ganglion in particular. And we need to consider whether there is any flexion or extension deformity of the segment given the degenerative changes in the patient, because that may change the location of the nerve, and it might not always be in the upper portion of the foramen, but closer to the disc height. So it's important to consider it because we want to avoid any injuries to it during our approach. What type of hernias are we going to treat with the extraforaminal approach? Hernias that are in the red circle, as we can see on the image, which are foraminal hernials and extraforaminal hernias in particular. And if we want to do a more internal or medial resection, we can also resect the recess area. But for this, we first need to release from outside in, expanding the approach in order to clearly visualize the structures. When they are extraforaminal, we don't need to go into the disc. We remain outside the canal all the time. Complications of this approach, immediate, are nerve or vascular injuries, which happen during the placement of the sheaths or the needles, also perforation of the exiting route and the injuries of abdominal and pelvic organs, and insufficient decompression and residual fragments are also found because there could be some remnants left behind. Early complications after a week, dysesthesias because of the manipulation of the nerve in the area, hematomas, because as I mentioned, this is a hypervascularized zone, and if a good hemostasis is not achieved, we may run into trouble. And then CSF cysts and infections. Cyst, if you have injured the dura and have not noticed, and infection, it can happen, but I do the procedure with antibiotic, saline solution, irrigation constantly, and that the complication is not frequent in my hands. Late complications are more associated with the patient's degenerative process and the normal course of these pathologies. So it is not really a complication, but the natural course of the disease. These include reherniation and instability, and we have to explain this to the patient because we want to make sure that there is no misunderstanding and that it's not a problem of the procedure. On the MRI, on the follow-up MRI, we might see a similar image. So that's why it's very important to record these surgeries as an evidence of having achieved adequate decompression. So what do we visualize with the extraforaminal approach? The exiting route, the axilla, which is Magnap's hidden zone. The descending route, we expand our approach towards the canal, and the roof of the foramen, which is the superior facet or the SAD as described in the American literature, and this will allow us to use this approach. Now, to be just on the hernia, not have to manipulate the structures on the AP, the needle should be pointing towards the center of the pedicle, the medial border towards the lateral of the pedicle, and in the posterior, it should be placed in the posterior third of the disc. That is the ideal position of the foramen. That is where we work when we have a foraminal hernia. If in the P, it is between the medial border and the spinous, and on the lateral it is penetrating the annulus, then that approach would be more indicated for a hernia in the canal, and it's not an extraforaminal approach anymore, but a transforaminal one. Here we can see the low placement of the working cannulas on the X-ray images. As I mentioned, on the AP view, the tip of the sheath reaches almost the middle of the pedicle, and on the lateral, the sheath is apparently all the time in the epidural space, but on the AP view, we know that we are actually outside the canal. And why in that area? Because we are outside where the hernia is located, and all we have to do is identify structures in order to do adequate decompression. What structures do we need to identify? We see here on the schematic the orientation or the image in the endoscope at 12 o'clock, the facet at 6 o'clock, the disc at 3 o'clock, the right pedicle in this case, the left pedicle, and at 9 o'clock, the exiting root. Always on the symptomatic side, the root will go to our right if the symptoms are on the right, or to our left side if the symptoms are on the left side. And here we can see on the center image that the root will always be located in the uppermost part of the foramen. So our place to attack is the base of the pedicle or the ascending facet, and that will help us work far from the root in order not to injure it. And it's also important to analyze on the MRI and determine the location of the artery that is with the root to avoid injuring it during the positioning of the elements. And when we go in, this is what we see on the right. In blue, the disc. A discography was then performed introducing the elements at 12 o'clock, the roof of the foramen, the tip of the joint or the facet, and at 3 o'clock, the pedicle. And this is what we always need to visualize before beginning the decompression, or else start to do a dissection to identify these structures before we go to look for the root towards the axilla of the zone where the hernia is located. So this is the image for a left side hernia. At 9 o'clock on the left side, we can see epidural fat. So we know that the structure that I'm going to release is over there. And to finish, I'm going to show you one case, a male patient who presented with pain and a compromised L4 root on the left side. We can see the MRI with an extruded fragment, migrated cephalad, extraforaminal. It's displacing the root outside the working field, and it gives me sufficient space to work initially, positioning the sheath at the level of the disc. I plan, based on the MRI, to determine the entry point at this level. It's 10 centimeters in our population. If I want to go in more lateral, we can do it. But in our population, I have determined that distance. The location, once the element is in there, you can see I'm showing here disc, pedicle, facet, and root. This is what I am identifying with the lens here. The first thing is that I do is to coagulate that area very well, because I want to avoid bleeding. And with RF, I try to identify the base of the pedicle. After I identify the pedicle, I follow it from 3 o'clock to 12 o'clock in order. This is all the ascending facet, which I dissect until I find the tip, and I dissect soft tissue to identify it better. When I find the tip or the base of the facet, I see that there is some motion when pressure changes, and that tells me that there is nerve tissue there. So I need to be careful. I do the decompression very judiciously. As soon as I identify the structures that will never change, which are the bony structures, then I proceed to release towards the hernia, releasing all that tissue in that area. I move the sheath, and behind the nerve is there. I haven't seen it. I know it is there. And I release all that area. I start to find rugged tissue that may correspond to the hernia capsule. And very patiently, using different elements, I coagulate and dissect, always in that area, always in that area. And probing there, I use different elements that help me dissect underneath the tissues to see if there is any loose fragment that I need to work with before I release. So you can see how the tissue changes. It becomes more pearly letting us see that it is a distal extruded component. And I'm dissecting the capsule, and the back is the canal, and that is where the descending root is, which is not the one I want to release, but I'm removing the fibrous tissue, because with the exiting root and that descending root is what forms the McNabb hidden zone. After having removed that tissue, and with very careful manipulation of the cannula in order not to injure the root and the ganglion, it bleeds a little. I move the cannula, cephalad. The sheath is moved, cephalad. The tissue has a different color here. That yellowish color is the color of extruded fragments that are lodged in the extraforaminal area. There's greater mobility of the sheath. All this release of fibrosis allows me to reject the root as I continue to look for the hernia. This capsule, there's a continuity here. Radio frequency is helping me with the dissection all the time. After having dissected all that tissue, with the manipulation, we can see how one of the extruded fragments comes out. I have more working area now. Pressure is lost. This allows me to manipulate the exiting root much better. And once the fragment is exposed, it comes out on its own, and all I have to do is remove it with the forceps. And as I remove the fragment, it's not just one, but multiple fragments. And that's why I was telling you that it is risky to have insufficient removal of the fragments, because it is not just one fragment that is creating the symptoms. There are other residual ones. So we continue to release the tissue, and with the sheath, I protect the root. I have not seen it yet. I don't need to see it as long as I know where I am in the 3D anatomy. All this is degenerative tissue from the hernia. And with RF, I do the annuloplasty. I finish the release of tissue and verify the decompression of the nerve and of the axilla. And I rotate the cannula towards 9 o'clock, and we can see the exiting root at L4. And this is a descending root. This is the axillary area, McNabb's hidden zone, which needs to be explored to confirm that there is no insufficient decompression. So the take-home message about this technique and approach for uniportal approach endoscopy: it is an effective procedure. It is minimally invasive, and results are satisfactory, and they, of course, depend on an adequate surgical technique, which has to do with planning and performance. Thank you very much. Thank you, Dr. Nicolas, for your talk. Now we will continue with Dr. Kuo-Ping Kuo. Dr. Kuo-Ping works in Taiwan. It is a pleasure to have him here. He is has been severely affected by the coronavirus pandemic. We had the third biportal endoscopy meeting in Taiwan in June, and unfortunately, because of the pandemic and all the lockdown, the event was cancelled, but we believe it will take place next year in 2021 in Taiwan. Dr. Kuo-Ping Kuo, welcome. His talk will be the relevance of BIS in high population cities. It's a very relevant talk because he's doing a very relevant work. You have many patients in your hospital, so welcome, Dr. Kuo-Pin Kuo.
Okay, please continue, please. We see your screen. Please continue, Dr. Kuo-Pin.
I'm Dr. Guo. I came from the north part of Taiwan. My hospital is a Catholic hospital center in the center of the Yonghe district of New Taipei City. Dr. Torres want me to talk about the high density. In this district, we have the 220,000 people living in a square meter of 5.7 square kilometer. So it's rather a very high density population in Taipei, in the Taiwan area. This is what we performed in the COVID pandemic. After of the 2020, this month 18, we have the confirmed case of the COVID about 440 cases with a death toll of 7 cases. That means our death rate is about 1.5%. We were lucky, and our government had made a very efficient measurement to make this kind of pandemic does not cause any kind of harmful to the Taiwan. I started with open MI spine surgery about 25 years ago, and I getting more interest on learning the endoscopic spine surgical technique in recent 3 years. I have been attending the workshop in spine endo, joint mat, and Richard Wood. And on the 2018, I read the first issue of the Best Journal. I meet Dr. Choi, and I start to jump into the wagon of the Best. And I attended the first Best International Symposium on the Baron Hospital, Jeonju, Korea training on 2018 March. During that time, I met 2 of my Spanish colleagues at the Jeonju. And I make another revisit on the August 2018 to then the second stage of the Foraminal Approach training. The purpose of this paper is to evaluate the clinical outcome and patient best in my hospital, including the interlaminar posterior approach, Foraminal approach, and the transforaminal lumbar interbody cage fusion. I correct all my experienced case to underwent the biportal best surgery for IPA, Foraminal, and best tissue. All the procedures were performed by me. I do the background analysis, including the gender, age distribution, diagnosis, operating procedure analysis, including the time span, selling volume, patient outcome index as anesthetic status, and the CBC data, ODI scale, and hospitalization date, and also the complication analysis and how I resolve the complication. And this is my learning curve. I started my first case of the best surgery on 2018, April 12. And during that time, this is my first case doing the lumbar discectomy. And I revisit Balloon Hospital, Jeonju, Korea, and come back perform my first Foraminal approach on 2018, August 17. And this is my Foraminal approach. This is an ASD case with a disc that occur around the axillary nerve. After we getting more experience on the best technique, around 116 cases, we performed our first best TLIF case that was on March last year. So best is as a matter of fact, is a kind of evolutionary technique. It never stop. You have a kind of wide dimension. So you never stop in one place. And this is the initial take I learned on my first case. The most we call the primary procedure, the interlaminar posterior approach with the ipsilateral and contralateral decompression. And the incision and the video. This is a case of L4, L5 stenosis. I'm trying to do the ipsilateral nerve root decompression with the transverse rule and go to the contralateral decompression, identify the facet, and define the junction of the IAP and SAP junction, elevate the IAP. I could see the underneath SAP. As you could see in here, the transverse rule, and use the calcium ranger. You could do the ventral lip contralateral SAP resection. So if you go further to the opposite area here, this will you going to see the exciting nerve. So this contralateral approach could give you access to the decompression with the exciting nerve and also the transverse rule at the same time. So just one level decompression, theoretically you could decompress 4 loops: the ipsilateral transversing loop and exciting nerve, and the contralateral transversing loop and exciting loop. And this is the bilateral approach. The skin text of bilateral is much simpler. This is a case of a degenerative scoliosis with a severe right side L4, L5 foraminal stenosis. Initially, we go just like Dr. Choi. We come from the transverse, go to the looking up, and go to the isthmic area, identify the IAP and SAP junction. And this is the starting point of our achievement to resect the tip of the SAP. As you go inside, and you are going to see more of the uniform strip of the ligament foramen, and using the spatial foramen punch and the chisel to resect the ventral rib and also identify the IAP and SAP junction. That's where we tip up the ventral rib of the SAP, and you could see the IAP loop. And this is the uniform that's right in front of you. The view is quite magnificent as compared to the uniportal. And you here, you could identify the cambium triangle, see the protruding disease, and you change to the 30-degree scoop. You could do the lateral reset decompression to access to the magnetic space. And theoretically, you could move further to the central decompression.
你的联络人没有符合先存的资料。
And after become more familiar and comfortable with the bilateral, and we move the best TD procedure. This is a case of the 56 female with the L4, L5 spondylolisthesis with listhetic instability and the spinal stenosis. This is our skin mark. Just as what you have done in the bilateral approach, transforaminal approach, you use this extension of this to identify the SAP and IAP junction, find your cambium space, do the annulotomy, and do the total discectomy. The beauty of this technique, you could use the scope to probe into this space to see the whole view of the disc. And using the dilator to dilate this space. You twist the dilator. As you see all the end plate of aeration. And the scope could come to the disc space to do the preparation of the disc space. Even if it is possible to do the anterior longitudinal lysis using the decoupulator. This never been done in the microsurgery, and only from the biportal technique, you could see the full space of the disc space. And using the tri to define the size of the cage, we will choose the 14 to 32, but mostly in our experience, 12 to 10 is enough. This case is a young case, so he has more flexibility. And using the active fuse, DBM, we recommend the artificial bone graft using the sticky glue type. Don't use the powder. Sometimes water coming will flush out all the artificial bone broke. And after finished case, you could do either the lateral recess and the central decompression. This is how the post-operative X-ray. From 2018, we started our first case of BESS on April, and up to 2 years later, we have already accumulated 288 cases underwent procedure of BESS with IPA, Foraminal Approach, and BESS TLIF. The male to female ratio is 120 to 68. The most is the most female predominant population. The age distribution is around 67 plus minus 10. Spinal stenosis is our major diagnosis, comprising 48.6%. The HIVD is 71, comprising 25%. ASD and failed back surgery is 10%. And spondylolisthesis is around 7 to 8%. And we even extend our indication to tumor and the cementation of the vertebroplasty with 20 cases, and the infection only 1 case. The overall average operating time is 121 minutes plus minus 47. This average standing erectile body is 23 liters plus minus 12. So this procedure demands a high flow of the setting. It's a water-based surgery. As to the ratio, the anterior approach and Foraminal Approach and BESS TLIF, the IPA and Foraminal is a comparison half and half. But if we were counting the BESS TLIF using the Foraminal, we see there was a more trend of using the Foraminal Approach to do the surgical end. Of all cases, we make some kind of comparison with the IPA, Foraminal Approach, and BESS TLIF. And we see this is a kind of this is mostly a female predominant population with the same kind of the age distribution is there's no significant. And in the Foraminal Approach and the IPA approach, the stenosis is comprising as a major indication. And the BESS TLIF is spondylolisthesis is served as the predominant patient group. And we compare the operating time, the internominal approach and the Foraminal, there's no statistical significance. So if you were comparing the BESS TLIF, there was about 50% more time as compared to the simple decompression procedure. Probably this is due to the instrumentation, the extra time for the instrumentation. The saline volume, the BESS TLIF consumes about 50% more saline as compared to the decompression group with the IPA and the Foraminal Approach. And we were doing the preliminary CBC data, either pre-operation and post-operation. We don't see any kind of difference in the decompression group in the IPA and the Foraminal. There's no any significant change of hemoglobin and hematocrit and white count and platelet. But we did see a significant change in the BESS TLIF either from the hemoglobin, there was much lower hemoglobin, hematocrit, and higher white count and lower platelet. So BESS TLIF in the biportal surgery is a kind of major surgery. Even even you are using this kind of minimal invasive, you still be very careful about the post-operative care. For all the hospitalization 来讲 we see there was a lower hospitalization day as compared to the best TIF. This data is a little bit higher because in the early stage we do spend more time that the patients to stay in hospital. But ever since in this year, the hospitalization they have been dropped to 2 to 3 days. So that means we have made a kind of significant improvement on the patient outcome. The ODS scale in IPA and the FATO shows significant improvement as compared to preoperative and postoperative. But in the best TIF, the improvement is not so that significant because I was speculating that this is because extra time and the instrumentation cause more pain and postoperative discomfort after the surgery. In our complication, though, in the internal posterior approach, we have one case of hypothermia, especially in the early stage. We are not familiar how to drop and cause the water spilling in the patient body. In the air conditioned room or the operating room, that will cause hypothermia. We have the wrong label and failed surgery in 2 cases, and it is followed by revision surgery. Durotay with 3 cases with conservative, and the most of this kind of durotay is a minor tear. It was being treated with the conservative treatment, and we call it thrombin sealant agent. And this is how we do the first case. We are not very familiar how to drip, and there was some kind of problem with the dripping. The water sometimes will leak through the drip, and sometimes it will be extravasated into the patient's body, especially in the air conditioner in the OR. That will cause significant hypothermia in the prolonged surgical time. But after the 10 cases, we are become more familiar and how to make correction. This kind of complication is almost rare in these 2 years now. We have a 3-case dural tear. This is kind of impending tear. We could see there was still some irregular membrane were intact, where the nerve root does not been protrude. And this is definite tear. In our measurement, that most this kind of tear is less than 5 millimeters. So sometimes it could be repaired by using the simple thrombin agent like the TCO or any kind of we call the patch, hemostatic patch that will easily make kind of repair. This is kind of video that show how the bipolar when you are doing the surgery, you could see clearly how you were doing. This is doing the epithelial decompression. As you see, this is accessory. This kind of due to the magnification of bipolar surgery, you could clearly see what you will familiar and make some kind of prevention on your technique. And this is very lucky. We could see it in a kind of magnification during the bipolar, and we stop our grabbing the nerve and don't make any kind of mistake. For the dual tear, 3 cases, the tear size is less than 5 minutes. It's easily subsides spontaneously. And our recommendation, if you have occurred, you don't use the hemovac. In our last 200 cases, we never use the hemovac anymore. We were either using the TCO or any kind of thrombin sealant, and we abandoned using the negative pressure drainage valve. Wrong level in the first few cases we are not very experienced, especially among the L4 and L5 and L5 as well in the hyperlordotic spine. When you do the surgery, sometimes you were going to make the wrong level mistake. This case is supposed to do it in L4 and 5. So it's supposed to we're very dismayed with doing the wrong level at L5 and 1. So this is kind of mistake when you do the L4, L5, S1. But later on, we realized even with the two incisions, we could do the transsegmental decompression on the L4, L5, and S1. So if it's unfortunate you make mistake, you still using the two incisions to make correction to the other level. And the wrong entry, this is most occur during the first few cases of the far-lateral approach. When you are not familiar with the anatomy of the transfer process and the facet joint, sometimes the entry is either too lateral or to lateral or going to downward. So you are not really doing going through the uniform row. Instead, you're going through the pedicle row. This will cause a disaster outcome. These cases we have already doing during the surgery using the CR. We doing after making this mistake, we stop right at the moment so that we could make some kind of prevention for this kind of the disaster consequence. This is the L2, L3, L4, L5 cases of the decompression procedure. We try to do the L5 S1. As you can see, the entry is simply to lateral and to downward. This is all occurred during the early phase of the learning curve. You are not quite familiar with the facet transfer process, isthmic junction. After that, we have learned the experience. The biggest goal is you need to find the IAP and SAP junction. If you could find this junction, it's a safe road for you to go to the transfer foraminal approach. And there was another case who have this is a kind of 82 female who have taken a long-term anticoagulation. He was doing the decompression using the far-lateral approach. Unfortunately, after surgery, he had a severe headache. And we do the CT scan, showed there was a kind of spontaneous subarachnoidal hemorrhage. And from also the treat conservative. As a matter of fact, we follow for 2 or 3 months. This case is still recovered quite well without any kind of back complication or consequence. Hydroretroperitoneal, we have the one case using the L2, L3 far-lateral approach. This is what we've done of the L2, L3, and the patient developed a kind of swelling of the abdomen. And using the CT scan, you can see the water extravasate through the retroperitoneal into the peritoneal cavity. However, this case is being treated conservatively. He was recovered 3 to 4 days with subsided the water. We using the Lasix, the antidiuretic agent, and he was recovered quite well without any kind of bad consequence. And in our complication of the breast TLIP, we have the grand mal seizure. One case after we doing the L3, L4, L5 spinal cell using the fusion procedure, breast TLIP procedure. This is what after the surgery, the L3, L4, L2, L3, L4, L5 unit frame fusion with the cage insertion. And during the procedure, we unfortunately tear the dura in our second cage insertion. But we see this is okay. Then we try to put patch up with the hemo patch. We continue to do the cage. We keep on doing the cage. And after the surgery, patient developed the grand mal seizure, and the seizure lasts about 2 hours after surgery. Lasts for 4-6 hours, and he developed rhabdomyolysis, whole pulmonary, and renal shutdown. He had been kept on the ICU pulmonary care and the renal dialysis, but we resuscitated back this patient, and she recovered after half a year. So the take-home message is, if you do this kind of bipolar, once dual tear occurs, the prolonged procedure is inadvisable, and don't overuse the radio frequency, and don't overstrain your patient. You should know where's your stopping point. In our conclusion, the best technique is a very powerful versatile technique. I think this might be the next alternative for the present tubular MS technique. Yeah, it's kind of evolving. The learning maturity period is about 40 to 60 cases for the internal post-procedure and the far-lateral approach. The IPA and the far-lateral decompression technique show minimal impaction and excellent and good functional outcome of the surgery. And the best TLIF look very promising. We think this might be a kind of in the next stage for the demand for the fusion technique. But we think there was still many things need to refine on the instrument, how to simplify the insertion and the fusion technique. This is more important is for the future development. My recommendation for the people who join the best waiter is you should love this technique. And don't think this is endoscopic procedure. And as you're doing the surgery, I recommend you try to supplement with a comfortable video system, using the big screen and good instrument. Don't always think the old instrument is enough. Your instrument needs to refine, and don't be overwhelmed by the breathing, especially in the first few cases. When you do the surgery, you have to encounter so many breathing. The more red screen, the more breathing, the more stronger you are. So don't be overwhelmed. And while doing the surgery, peace and calm, and know where is the end point. And this is you as a bipolar surgeon. And thank you for your attention. We always say we're supposed to have an international meeting of bipolar on the next month, but it had to be canceled due to the COVID pandemic. We hope we could see each other on the 2021, and we'll host this kind of symposium. Welcome every one of you to come to Taiwan. Thank you very much.
Thank you, Dr. Kuo, for your talk. You have a lot of experience. You are doing instrumentations with this technique, a TLIF, a minimally invasive technique. Anybody who operates runs into complications, but the important thing is to know how to manage them. And what Dr. Kuo has done in a short period of time is very significant. And I think that the work done in Taiwan is deserving of congratulations. We have the last 10 minutes, and we will hear from Dr. Daniel Iglesias, who works in Quirón in hospital in Zaragoza. It is an honor, doctor, and your topic will be why train in spine endoscopy or endoscopic spine surgery. Thank you for your patience. Yours is the last talk. Thank you very much. Well, thank you. I hope that you can hear me. Yes, we can hear you very well. Well, thank you, Dr. Torres. I wish to thank the Society for this invitation. It's very successful. I've been very active in webinars. And there are twice as many people in this webinar than in others that I have attended. So I wish to congratulate you on your organization and for the topics. I've been doing uniportal endoscopy in my city in Zaragoza, a city of 700,000 inhabitants. So endoscopic surgery in Spain is not really widespread. only one team, which is that of Dr. Gonzalez and Dr. Gina Sinivisa, is perhaps the only one that is doing endoscopic biportal surgery. Other societies are becoming interested in these topics, but let me tell you that in daily practice it is not yet generalized. There always has been interest towards doing a smaller incision. However, one technique hasn't substituted the other one. When we talk about the disc hernia, first with better retractors, we could do discectomies, then tubular techniques came about, and finally, the endoscopic techniques came along. But it's not that new techniques have replaced fully the old techniques. In this survey by AO Spine, 817 respondents, including neurosurgeons and orthopedic surgeons, the vast majority of people do the classical microdiscectomy. The vast majority of the surgeons do the classical microdiscectomy. In clinical practice, there are very few centers that are pioneers. Only few centers are pioneers like Korea, Taiwan, but in Europe, that hasn't been the case. And why use endoscopy? Because everything comes together and fits to make it a gold standard in the future, because there is less postoperative pain, earlier discharge, less bleeding, less infection, faster recovery. And since you hardly touch the spinal structures, there will not be fibrosis, adhesions requiring revisions. We are not going to destabilize the spine. So if we have to revise that surgery, there will not be fibrosis, and it can be done with local anesthesia, and that is critical in coronavirus. This morning we operated transforaminal cases with local anesthesia and L4, L5, so that allows us to operate very elderly patients who have other comorbidities, people who would have never been able to be operated without this surgery. And it is safe surgery. It has low rate of complications, less infections, and less skin problems. The interest for endoscopy that has grown, as we see in the publications. There is great interest in training, and it offers very clear benefits. But in order for it to become gold standard, it needs to achieve several things. So we need to demonstrate whether it is less aggressive. There shouldn't be any increase in complications, and you should be able to remove the hernia correctly. And all this must be maintained with the same clinical outcomes or with improved clinical outcomes. So endoscopy in its different versions will take over from conventional surgery if it meets all those criteria. About being less aggressive, classical surgery devitalizes the muscle. It causes scarring and fibrosis and may lead to failed back. And endoscopy improves parameters in terms of the surgical aggression. We know that we need to achieve a good clinical outcome because the spine is a great stabilizer. So in a transforaminal approach, for example, we do not damage the muscles, and apart from not having complications, we need that surgery to be successful. This was an analysis of 10,000 surgeries, and there is a 4% unsuccessful surgeries, very similar to the open procedures, but it may be perhaps that the plan was not appropriately made. We need to be very thorough when we do central or migrated hernias or of the axillary type. We need to avoid any surprises with an incomplete release. And endoscopic surgery has shown to have an immediate better clinical outcome. It's not that long and difficult postoperative period and less residual pain, and recovery is faster return to sports or to work. These are all the papers showing similar rates of complications, but even improved outcomes. And here this publication says now that endoscopic surgery is better than open surgery in terms of outcomes and complications. It is compared with microdiscectomy and tubular surgery, showing better clinical outcomes, less complications, and earlier return to work. And this is a recent paper of March of this year, where they say that in this systematic review and meta-analysis, the rate of complication is lower with endoscopic surgery than with classical traditional surgery. There, we still have another tool to justify the use of endoscopic surgery over classical techniques because we have less complications and the same clinical outcomes. But this is not all. Disc herniation is not the only condition that we will be able to treat with endoscopy. As we can see in the Gardner diagram, when there is a peak of inflated expectations, then there is disillusionment, and finally there will be a plateau for endoscopic surgery. And to the right, by Hofstadter, we see the red line that shows that as we increase the complexity of the processes, canal stenosis or more complex processes at the cervical or thoracic level, that is where we will find the benefit of endoscopic surgery. The aggressiveness of surgery is less, and the benefit of endoscopic surgery is seen if we're faced with a canal stenosis of cervical pathology. That is where we see the greatest benefit of endoscopic surgery, and how endoscopic spine surgery can be used in many indications that are below the waterline, although the disc hernia is the tip of the iceberg. So these are all things in which we're going to be able to use endoscopic surgery. It's an accepted approach. And there are indirect signs that endoscopy will become the gold standard. There is a higher number of indications, a higher number of surgeons that train. There is a growth of publications, more cases regarding overall spine implants, and this therefore points to the fact that endoscopic surgery will become the gold standard for the future. I will say that it has never been simple. Other areas have had difficulty in becoming established, like knee arthroscopy for the treatment of the meniscus. It was a long time before we went from open meniscal surgery to arthroscopy, and the same thing happened with shoulder and rotator cuff treatment, and also cholecystitis treatment. First it was open, then came endoscopy, and those pioneers had to travel along a long road until they became established as gold standards. And the same will happen with endoscopic spine surgery. And it is clear that in order to train in endoscopy, we need comprehensive education, because the reality is that we are dealing with processes that had good results when they were approached openly. So we need very thorough and comprehensive training to make sure that we can ensure the same types of outcomes. The idea is to train. There are many surgeons that publish their surgeries on YouTube. We have the possibility of visiting and of taking theoretical courses and watch experienced surgeons. So the important thing is to improve the outcomes for the patients, but our learning curve shouldn't imply having complications because of deficient training. Thank you very much. Thank you, Dr. Iglesias. And to finish, I wish to thank you all. It was 3 hours of endoscopy. It causes fatigue. Dr. Iglesias, thank you very much for the support, evidence support that you provided. To close, the press in Ibiza was very interesting in disseminating this webinar. It was a very important event which was disseminated by the written and by the written press. The same was true for Colombia. So we wish to thank the people in Ibiza, and I wish to thank you all and congratulate you all. This has been a success. And to finish, I'd like to thank the sponsor, this Korean company, a company that develops instruments not only for uniportal surgery, but also for biportal surgery. I would also like Dr. to ask if there are any questions. We can open the microphone for an additional 5 minutes for questions. And Dr. Well, I wish to thank all the panelists, Dr. Kuo, Dr. Choi, Dr. Gonzalez, Dr. Cantu. But Dr. Dai, could you give us your last words to close this webinar?
Thank you very much. It's a very wonderful experience. Maybe we can meet again soon. Thank you, Dr. Torres. Thank you. Thank you.
Any more final words? I think that we accomplished our goal. I wish to thank you for my country. This is very important for the future of our religion, endoscopic spinal surgery. Thank you very much. If there are any final words. Well, yes, Fernando, I wish to thank you for organizing the webinar. I think it has been a great success. It has been very interesting. And it's 5 in the morning now in Europe, and I think that we need to go to bed. It was a pleasure to see you all. It has been a pleasure to share with Dr. Choi, Dr. Kuo, and with all of the other panelists. A very important thing, the Colombian Society of Orthopedic Surgery and Traumatology and the Board of Directors of the Society of the Spine Society, because we need to thank them for the logistics. They made this possible. I need to thank Anita, Gabriel, Nora Luz, anybody else? Dr. Iglesias, Dr. Cantu, our pleasure, Dr. Ramirez, Dr. Oh, it was so wonderful to have you from so far away. Thanks to all.
Mm-hmm. Mm.
As a Colombian, Fernando, I wish to congratulate you. You showed the good, very nice side of Colombia. In Colombia, we are innovators and we are forerunners in Latin America. In May of 1993, that's when I started my training in the US with these procedures that I showed. That is why I like the Foraminal Approach. I promoted, I trained in it, and I have been doing it with very good results. I wish to thank the colleagues from Spain who will go have breakfast now, and to all our friends. Fernando, as president of the Colombian Society of Spine Surgery, please continue to organize these webinars, continue to show experiences in different parts of the world. In spine is one of the most difficult specialties in medicine, and nobody is the owner of the truth. The important thing is to show honestly what we do, the good, the bad, and the ugly, because there. I've been a spine surgeon for 40 years. Dr. Cantu perhaps is older than me in this work, but the important thing is for all of us to get together to show the good, the bad, and the ugly, and we all learn. But thank you very much. So we're leaving. If there are no questions or no comments. Excellent contribution. Dr. Cantu. No, Fernando, I want to congratulate you. It was a success. We are always learning new things from what others do, and that is how we grow and how we improve in our specialty. I also trained in transforaminal endoscopy, but then the interlaminar and the biportal that you do is very important. And so I'm not just married with one approach. Anything that we can use to solve cases, we will. accept and adopt, and always thinking about the safety of our patients and bring them back to their work and faster. So yes, we learned a lot today. Thank you, Dr. Cantu. Well, thank you. We will now close the meeting. The meeting is adjourned. Bye-bye.
See you, those of you in Taiwan, 2021.
Nos vemos en el dos.
We will be hosting for the symposium for bipolar. Okay? Hope everybody well.
No,